My name is Eddie Cassidy, and I'm the chairperson of the Irish Lung Fibrosis Association. You are all very, very welcome to this morning's event, which is ILFA's first patient information day of 2024. ILFA was set up in 2002 to provide research, education, advocacy, and support to lung fibrosis patients and families. This year, we have reached our 22nd anniversary as a charity and registered company. And it is with great credit to ILFA's founders, board members over the years, Gemma, Anne, and other administrative assistants, and of course our fundraisers and donors, that the charity has grown and developed. A lot of hard work goes on behind the scenes, and this year is especially important for ILFA as we have appointed our new CEO to lead the charity into the future. This is a wonderful and exciting milestone for ILFA, and it gives me the greatest pleasure to warmly welcome and introduce you to Maureen O'Donnell, CEO of ILFA. And on that note, I'm going to fade into obscurity and Maureen will take over. Now, Maureen, it's all yours. Bye-bye.
Thanks, Eddie. Thank you so much. I'm so excited to be starting with ILFA this week, and it's been an amazing first week, and I'm really looking forward to the work going ahead. Particularly today's patient information session. We've got a wonderful lineup of speakers for you today, and I'll just jump right into it if that's okay. Our first speaker is Dr. Eoin Judge, and Dr. Judge is a consultant respiratory physician in Connolly Hospital, Dublin, where he has developed and leads the hospital's interstitial lung disease service. He's an associate clinical professor in the Royal College of Surgeons, Ireland, and a member of the Irish Thoracic Society's ILD committee. Prior to commencing his current role, Dr. Judge undertook a fellowship in ILD in the internationally renowned Royal Brompton Hospital in London. He was subsequently appointed as consultant respiratory physician in the Liverpool University Hospital's NHS Foundation Trust, where he worked as a specialist in ILD and a lecturer in the University of Liverpool. He is actively involved in ILD research and has been a principal and sub-investigator on a number of trials and studies in the field of ILD research. Dr. Judge, you are very welcome today.
Thank you very much, Maureen, and very welcome to you, and congratulations on your new role. Just share my screen there. Okay, so good morning, everyone. I'd firstly like to begin by thanking ILFA for inviting me to speak at this meeting this morning. So the topic of my presentation is an overview of advances into diagnosis and treatment of IPF. So the last few years have certainly been a very interesting and exciting time for those of us who work in the field of pulmonary fibrosis and IPF. Although many challenges prevail, significant developments have been made in understanding, diagnosing, and treating this disease. So during the time allocated for this presentation, which I think is approximately 15 minutes or so, I'll provide an overview of some of the more notable recent developments in this area, and I'll be happy to answer any questions which you may have. So firstly, to developments in diagnosis in IPF. So IPF, as we know, is a progressive fibrotic lung disease, which is characterized by worsening respiratory symptoms and lung function. We know that increasing age, as most patients are diagnosed aged 60 years or older, male sex, approximately 70% of cases are male, and a history of cigarette smoking and inhalational exposures are risk factors for the development of IPF. In recent years, increasing awareness of the clinical manifestations of IPF, such as progressive shortness of breath and cough and fibrotic crackles, amongst patients, GPs and specialists, and the more widespread use of chest CT scanning has contributed to a rising incidence and prevalence of IPF, and most likely the earlier detection of IPF. And this figure here, not sure if you can see my pointer, but illustrates the rising incidence and prevalence of IPF amongst a very well-studied cohort of patients in the US Veterans Group, over a 10-year period. This was recently published. Another key development in the diagnosis of IPF in recent years has been a more structured approach to IPF diagnosis and care, with an emphasis on a multidisciplinary diagnosis. So, as highlighted in the most recently published international guidelines on IPF, multidisciplinary discussion that integrates clinical, radiological and tissue biopsy results where available has been shown to improve diagnostic confidence and indeed alter therapy in a substantial number of patients with IPF. So, for example, recently published studies have shown that an ILD multidisciplinary discussion meeting results in a diagnosis of approximately 3/4 or 75% of cases where there is an uncertain diagnosis before the meeting, and that it also establishes that a previous diagnosis of IPF was actually incorrect in about half of cases. So this has been a significant positive development, I think, in IPF and ILD diagnosis. So this slide here illustrates the multidisciplinary approach to diagnosis in IPF and ILD, which is instituted in Connolly Hospital and in other ILD centres in Ireland and overseas. And this approach has been established as a best practice standard of care approach to diagnosis in IPF. Basically, all cases of suspected ILD are referred for high-resolution CT thorax, or HRCT, which I'll talk about in a little bit more detail shortly. And the patient's clinical details, blood tests, imaging, are then discussed at an ILD MDM by a respiratory physician, a thoracic radiologist, a histopathologist and surgeon, and/or rheumatologist where appropriate, in advance of formalizing a diagnosis. At this point, some cases are referred for further biopsy and are then rediscussed at the MDM. Some cases are referred for a bronchoscopy and bronchoalveolar lavage, or BAL. And that's where cells that are taken at the time of bronchoscopy are assessed to see if they are compatible with IPF or indeed a different disease. So, as mentioned, this approach to IPF and ILD diagnosis has been shown to significantly improve the accuracy of diagnosis and reduce the number of unnecessary investigations, such as lung biopsy, which are in many cases, in most cases, not required. So the diagnosis of IPF relies on appropriate CT imaging, and the high-resolution CT thorax is the cornerstone of diagnosis in ILD. And in recent years, great focus has been made on improving the quality of this imaging. And indeed, the most recent guidelines specify specific technical parameters for image acquisition and reconstruction. And this, as I said, leads to better quality imaging and hence better quality diagnoses. And here we can see the CT scan, the high-resolution CT scan of a patient with IPF. And you can see the characteristic pattern of ILD known as UIP, or usual interstitial pneumonitis, with reticular change and honeycomb change and traction bronchiectasis, mainly located in the lower part of this person's lungs. So the increased use of CT scanning for other clinical conditions, for example, in emergency departments for detection of pulmonary embolism, lung cancer screening, indeed just in terms of staging of other diseases and so on, has led to the detection of what are known as incidental lung abnormalities, or ILAs. So an ILA is defined as an incidental CT abnormality in patients where ILD was not actually previously suspected. The significance of these ILAs has been extensively studied in recent years and is not completely understood, but we do know that a proportion of these incidental CT findings can progress to IPF in some patients, particularly those patients who may have risk factors for IPF that I previously mentioned. Thus, the CT scanning may actually facilitate earlier detection of IPF, but again, further research, which is ongoing, is required to determine the optimal approach to screening for IPF and indeed other ILDs. So again, I've shown this image of a high-resolution CT thorax of a patient who actually had no respiratory symptoms, but who did have ILAs in the form of reticular change and some ground glass change in their lungs. So this particular patient was followed up over a period of time for the development of interstitial lung disease, progressive interstitial lung disease. So unfortunately, however, the qualitative visual assessment or reading of high-resolution CT scans by even the most experienced chest radiologists for the diagnosis of interstitial lung disease is limited by quite a high inter-observer variability, and shows a low sensitivity actually in the assessment of changes over time, which are now very important in terms of assessing the disease trajectory and indeed the development of disease in some patients. So, for example, that characteristic honeycomb change, which is a feature of UIP, which I showed in a previous slide, and which is a predictor of worse outcomes in ILD, is often actually misclassified, especially when the patient may have coexistent emphysema on their scan. So qualitative CT software has been developed in recent years, and this enables the quantification of patterns on high-resolution CT with results that are much more objective, reproducible, and sensitive to change, and predictive of disease progression. And applications have been developed to provide a diagnosis or pattern classification, and these applications are mainly based on artificial intelligence. And I've shown an image here of the caliper quantitative software, which has been studied and developed in recent years. And I think it shows some really nice images of where the future may lie in terms of looking at CT imaging for patients with IPF. And on the top row, you can see time point 1. And on the bottom row, images D to F, you can see time point 2. And you can see very clearly that there has been progression in the fibrotic changes in the form of reticular change, which is the orange colored change on the scan, and honeycomb change, which is the darker color over the time. And this, as you can probably visually see in comparison with the panels on the left, is much more subtle and much more kind of accurate way of assessing the progression and indeed the presence of these fibrotic changes. So it's very clear that great progress has been made, but unfortunately this software and so on, and the use of artificial intelligence does require a significant further level of research before it can be actively used in clinical practice. But this is a really rapidly developing field, very exciting field of research in ILD. So hopefully we'll make progress on that very soon. Another key area of development in interstitial lung disease and IPF has been an increased understanding of the genetic basis of this disease. Recent studies suggest that IPF is a highly polygenic disease with multiple gene variants associated with disease susceptibility. The variant which seems to show the strongest association with pulmonary fibrosis development and pathogenesis is a polymorphism in the promoter region of the MUC5B gene, and this leads to an increased risk of IPF development, perhaps to, a six-fold increase indeed. And many other gene mutations. Sorry, I think I just got a notification there on the screen, but I'll keep going. Other gene mutations, such as surfactant protein mutation or SP mutation, has been implicated in fibrosis. Taken together, testing for disease susceptibility genes could help personalize the radiological follow-up of individuals at risk for IPF and the treatment of patients with IPF or ILAs. For example, if patients with ILAs have some of these genetic abnormalities, then these patients perhaps may require more frequent radiological follow-up compared to patients who don't have any genetic variations or susceptibility genes. But really, this is an interesting area of research and further investigation of the clinical utility of these developments, and the role of gene testing in IPF management is required. Despite advances in the quality of high-resolution CT scanning and multidisciplinary discussion, the establishment of an accurate diagnosis of IPF and other forms of ILD can be very challenging. An ideal diagnostic biomarker could reduce the rates of misdiagnosis and improve accuracy in diagnosis. And in recent years, blood biomarkers that can enhance diagnosis and help determine prognosis and treatment response in IPF have been identified. For example, patients with IPF have been found to have higher blood levels of markers for alveolar epithelial cell injury, such as KL6, and extracellular matrix remodeling, such as MMP7 and periostin. And indeed, higher levels of peripheral blood monocytes have been shown to be strongly associated with disease progression and all-cause mortality. Other biomarkers, as shown in this table here, have been identified that may be able to predict or measure the treatment responses to antifibrotic therapy in patients with IPF. Again, further studies are required to determine the clinical utility of these novel biomarkers in the context of the current standard of care. But taken together, these developments could indeed represent a step towards precision medicine in IPF. And now to discuss some of the developments in the treatment of IPF. So earlier in the presentation, I discussed how a multidisciplinary approach to diagnosis is accepted now as a standard of care. And similarly, national and international guidelines now emphasize the importance of a more cohesive, structured approach to IPF care, with particular input from dedicated ILD specialist nurses and ANPs, physiotherapists, dietitians, psychologists, and palliative care practitioners. And really, all patients with ILD and IPF should have access to these multidisciplinary therapies. For example, as I've shown at the top of this slide here, pulmonary rehabilitation is a key form of treatment for many patients. And pulmonary rehab delivered by physiotherapists or trained physiotherapists and trained nurses has been shown to improve clinical outcomes in patients with IPF, including improving dyspnea or shortness of breath levels, and quality of life. Also, access to palliative care has been shown to be beneficial in alleviating symptom burden for patients and caregivers. And the accepted benefits of these multidisciplinary delivered treatments really does further support the plan of structuring ILD care around ILD centres throughout the country and providing greater community-based access to these treatments so that every patient with IPF can access these important treatments regardless of their postcode. The standard of medical care or treatment for IPF has also evolved very significantly in recent years. There are now two established antifibrotic agents, pirfenidone and nintedanib, which are approved for the treatment of IPF. Both agents have been shown to slow lung function decline, and in more recently published secondary and pooled analyses, both have been shown to improve clinical outcomes, including respiratory hospitalizations and mortality. However, neither agent, unfortunately, has been shown to improve patient symptoms. And indeed, about 20 to 30% of patients in clinical trials and real-world registries are actually unable to tolerate these medications due to long-term side effects, which are primarily gastrointestinal. And really, this highlights the need for more effective and better tolerated medical treatments. And this figure was taken from a recent meta-analysis of a large number of patients, about 13,000 patients across 26 studies. And the meta-analysis included 8 randomized controlled trials. And this is a forest plot of the relative risk for all-cause mortality in the randomized controlled trials of antifibrotic therapy. And as you can see on the left side of the forest plot here, the antifibrotic therapy reduced the all-cause risk of mortality compared to the non-treatment group, non-antifibrotic treatment group. And indeed, antifibrotic treatment was associated with a decreased risk of all-cause mortality in the pooled analysis, and the effect was consistent across additional subgroup analyses, including stratification by the individual studies type, risk of bias, duration of follow-up, and so on. So perhaps very importantly as well, antifibrotic treatment has been shown in this retrospective meta-analysis to reduce the risk of acute exacerbations of IPF, which is also an important benefit of these medications. It is clear, as mentioned, that we really do need better medicines to treat IPF. And I suppose the encouraging news is that there are multiple trials of potential treatments for IPF ongoing across the world at present. And I've shown this rather busy slide to illustrate just a portion of the many treatments that have been identified in preclinical and early clinical studies for the treatment of IPF. And these targets include growth factors, cytokines, signaling pathways, all of which are involved in the fibrotic process. And most of the trials target these individual factors. In Connolly Hospital, I'm pleased to say that we were selected as a clinical trial site for the international Fibroneer study, and some of our patients with IPF are currently participating in this trial. And the trial is a phase 3 trial, and it's evaluating the safety and efficacy of a PDE4B inhibitor, which was shown to reduce the rate of lung function decline as shown by FVC in a phase 2 and randomized control trial. And we really do hope that this trial, along with the many other ongoing trials, will lead to improved IPF therapies. So to finish, it's very clear, I think, that the landscape of IPF diagnosis and treatment continues to evolve rapidly, and it's been driven by advances in research, technology, and clinical practice. It's clear However, as well, that challenges such as early diagnosis and different patterns of disease and treatment options, which are quite limited, do remain for patients. Overall, however, I think this really does highlight the need for improved patient education and supports as delivered by organisations such as ILFA and ongoing research and collaboration across the world. So thank you.
Thank you very much, Dr. Eoin Judge. And unfortunately, we've run out of time on your segment, but in maybe 30 seconds, you've provided some really fascinating information about improved testing, earlier diagnosis. The question that's being asked, I suppose, is that then having an impact on the average life expectancy prediction, or is that information that was given before still current?
Yeah, it's a good question. I think it's probably fair to say that we're getting a better, through these developments and studies, particularly the international trials and so on, we're getting a better perspective on the disease trajectory in IPF. And we know that it's not a one-size-all approach. It's very different for some patients, and indeed, in the results from the Impulses trial show that actually 15% of patients, their disease stayed stable or actually got slightly better in the placebo group. So really, it's very variable. I think we're getting a sense that with developments such as antifibrotic therapy, outcomes are definitely improving for IPF patients.
Okay. Well, that's great to hear. Thank you very much for that, and again for that wonderful presentation. Next up, we have Helen Mulryan. So Helen began her nursing career in 2002 when she began a 4-year nursing degree in the University of Galway. On qualifying in 2006, she took up staff nurse's role on the respiratory ward in Galway University Hospital, spent 9 years there as a staff nurse and clinical nurse manager. In 2015, an opportunity arose to work with the respiratory clinical nurse specialist, and this then brought her on the path towards a postgraduate diploma in respiratory nursing in the University of Limerick. After that, she worked as a clinical nurse specialist before taking up a candidate advanced nurse practitioner role. Between 2018 and 2022, she completed her nurse prescribing ionizing radiation prescribing and a master's in advanced practice. Currently, Helen works as a respiratory advanced nurse practitioner in Galway University Hospital as part of a wider respiratory team. So you are very welcome, Helen.
Thank you so much, Maureen. You're very welcome, and wishing you all success in your new role. It's very exciting for you. And thank you to ILFA for asking me to speak this morning. I'm going to hopefully share my screen. Today, I'm going to speak to you a little bit about my role as a respiratory advanced nurse practitioner, working with patients with pulmonary fibrosis. And also, I'm going to touch briefly just around some aspects around entitlements. It was a special request, so I might be a bit stuck for time, but I'm very happy to share my slides and all the links that I have. The reason I called my talk Every Day is a Learning Day is really because it is. And what I know today, I'll know more next week and the week after. And it really has been evolution of a role and my knowledge. In 2002, when I started my degree, ILFA was in its infancy. I was starting my degree program, and I have such clear memories. As a student, the one thing you were really let do was do the admission paperwork, because you weren't really great at much else in the early days. And I remember writing the words pulmonary fibrosis so clearly, and not having the concept of what I was writing, and not having the understanding, and not knowing the role I would have today, and how my knowledge has grown and my understanding. But it continues to grow every single day. My role, I'm very lucky to work with another advanced nurse practitioner, Donna, and it's great to have the support of another person. And I suppose our role, one of our patients always refers to us that we're like Swiss Army knives, because we can turn our hands to anything. And we seem to always have some form of an answer, or we'll find an answer for a question, which is a great compliment, I hope. But really, it's the charter and the position statement, I really think, for IPF that guide an awful lot of what we do. And I'm going to touch briefly, I suppose, a little bit about my role. First and foremost, and Dr. Judge touched on this around the multidisciplinary team. It's so important. I'm part of a bigger team. I'm not one person, but being part of a team brings such diversity of, opinion, of conversation, of thinking, of clinical applications. It's so important to have such a wide, and we are very lucky. I'm very lucky in Galway to work with physiologists, physiotherapists, dietitians, other nurses, physicians. It's amazing to be part of a team, and that really helps to deliver the best care we can for our patients. And when you come together as a team, when there are problems or issues, it really gives strength to what you can offer your patients. And it's just so important. And I'm very lucky to be part of a really good team. It's my job to be a really good communicator, and that can be very difficult. And what's really important is that communication is tailored to fit the need of the individual. We're all different, and how we like to receive information can be very different. It's not one fits all. And often this patient journey is so complex. And when we meet people first, it is like a jigsaw, and the pieces are all muddled up. And we know from the literature, from the research, from patient experience, that getting a diagnosis can take quite some time, and it can take some time for the pieces to get put together. But it's really important for me as part of the team to help put those pieces together. And I'm with the person from the very beginning, all the way through their journey, all the bumps in the road, and we work together. The other thing is we're becoming so amazingly culturally diverse. It's to adapt to other means of communication and understanding that needs can be very different. But every day is different, and how I might communicate with somebody today will not suit the person tomorrow. And I have to be really mindful of that and take on board the patient's needs. My job is also to provide a fairly extensive phone service, which we're very proud of. The most questions we get are around medications and oxygen therapies. With the medications, there'll be a lot of questions around side effects and interactions, going on holidays. Do I bring my medicines with me? How do I travel with them? And the same with oxygen. Interestingly, I think hopefully that we are good communicators, because a lot of the questions we get are actually just people ringing to say, this is my plan. It's a good plan, isn't it? And we just say yes, because hopefully we've given the knowledge, we've provided appropriate education, and we've communicated in a way that people are comfortable and happy with what they're doing with their medications and their oxygen therapy. This time of year it gets busy because we'll be soon getting into holiday season, so it's helping people to go away on their trips and their weekends away, which is always a nice thing. We work really closely with our physiotherapy colleagues, and we work with our patients to help them get to pulmonary rehab or exercise classes online, like with ILFA, any way that we can help facilitate some form of exercise. And traditional exercise may not suit everybody. There may be other comorbidities, other reasons why exercise is difficult. So we always look to try and tailor some form of exercise to suit the person and their needs. And I'm really lucky to work with a team that are happy to do that and provide that service, which is great, because we all know that that exercise is critical to keep people mobile, to keep them strong and fit, so that they have good quality of life. I also work very closely with transplant services. Myself and Donna would help coordinate the referrals to the transplant service, and it's another part of the journey that we work really closely with people on, and we help to navigate something that's quite difficult, quite in depth, quite time consuming, and to help them, I suppose, organise getting to appointments, make sure the paperwork is correct, get everything off to Dublin appropriately, and just help them navigate that whole journey. And then there's other aspects of our role. And I think what's really important about our role is the patient is obviously key, but also they have families, they have friends, they have loved ones, people who help them. And there's another aspect to that. And, you know, we offer a service to them as well. It's difficult to be a carer. It's difficult to be somebody's loved one when you're concerned about them and they're unwell. So when I look back and I think about being a member of the MDT, of our communication skills, of coordinating things, we're also working with the person's family, loved ones, friends, whoever is their support person, and we support them as well. We offer emotional support. Obviously, it's a very difficult journey, and sometimes people find it easier maybe to talk to us than their loved one if they have some concerns. And they may come to us first, which is a great privilege to think that there's trust in you that you can offer that to somebody. We provide practical support. So things like organising the oxygen for holidays, you know, they want to go somewhere, or, you know, changing concentrators to portable concentrators when they're dealing with oxygen, getting to appointments, where will they park? There's lots of other little bits and pieces that we do. And we also work really, really closely with our palliative care colleagues who provide an amazing service, both in terms of hospital care and community care, because symptom management is hugely important for us in our role, hugely important that we look after the patients in that way, because it's quality of life. And we want people to be able to live their best lives, do what they want to do, and that we can manage the symptoms as much as possible. And that really is just a snapshot, I suppose, of some of the things that we do. Every day is very different. But practically, one of the things that kind of I took on a little bit lately was looking at things like entitlements and how people can apply for things or look into things. And I'm going to have, I think I'm doing okay for time. It's a real whistle-stop tour. But I want to talk a little bit about entitlements because I don't know what it is, but we're all afraid to apply for anything. It's like we're afraid we're doing the wrong thing if we look for something or even apply for something. And the take-home message from this is the worst thing that they can say is no. It's worth applying for things because you just don't know what you might be entitled to until you look into it. So I'm going to have a quick look at what's out there, where to find the information, and maybe just some other supports that people mightn't be aware of. And I'll start by saying just yesterday, I had a lady ring me. I had asked her to apply for a medical card. I really thought that she should. And she really felt she wouldn't be entitled. But I kept saying, please do, and just see. And so she rang yesterday to say, well, actually, I didn't get the medical card, but I got a GP visit card and I'm thrilled. And I only did it because he kept saying to me to please do it. So really, you know, it is worth applying for things. So obviously, under 66 years of age is slightly different. It's under the pension age. And for most people under 66, their first entitlement would be illness benefit in the setting of being off work with an illness. And this will last for about 2 years. And then you change over to things like an invalidity pension or disability allowance. Often people don't actually apply for things correctly. And I've added in some links and that I'm happy to take questions from anybody at a later date or anything like that. But people should think about their age and what they should be applying for. And GPs are really great for giving advice on this as well. There's something called the household benefit package, which interestingly, a lot of patients don't apply for, a lot of people don't apply for, and it is help with the cost of your energy payment, which we all know that energy costs are escalating hugely. It also covers the cost of television license. I won't go through everything because I know I don't want to go over time, but really when you're over 70, it's a little bit easier when you are applying for things. But even when you're under 70, you can still apply for these with some basic paperwork. So I would definitely recommend anybody who hasn't applied for anything like this, definitely have a look online and fill in the paperwork and fill in online. It's €35 a month, which is small, but beneficial when the bills are quite so high. And really the only restriction on that is only one person per household can apply for it. The fuel allowance is another thing that often people don't apply for, and it's something to help with heating over the winter months. Again, it's only one individual per household. It usually begins around September and into April, and it is €33 a week, which is not insignificant. And there's two ways to receive that, either in a weekly payment or in 2 lump sums. Really, the only thing is you can live with your spouse or a cohabitant, somebody that you live with, but it's only one person per house. Now, what most people are struggling with at the moment, I think, is that the primary care schemes online, it has gone online to apply for a medical card. When you apply for a medical card, if you're declined for that, you're automatically assessed for a GP card. Sometimes people struggle a little bit with the online service, and I know in Galway we're happy to help people navigate this as best that we can. But it is all online, and it's all on the primary care schemes, and there are links to the information that you would need to look at eligibility. Covers your GP care, some dental, optical and hearing services, covers community services, short-term counselling in community care if you have, in primary care if you have a medical card, 8 sessions of counselling, so short-term, and obviously reduces the cost of any medicines you're paying for as well. Now, when you're under 70 years, obviously there is a means test, but it is all online. But the point I want to make about the medical card when you're under 70 is certainly there's a means test, and there are some restrictions, but there is also discretion. So if a medical need far outweighs the income thresholds, they will consider it. And obviously we're happy to fill any paperwork and give supporting letters, and that would be the same for any service to help you try and access a medical card. Also, if you had an acute episode of care and things change quite dramatically for a period of time, they do have the discretion to issue an emergency medical card for 6 months, which would be very beneficial. Over 70 years, it's a little bit easier. The thresholds financially have increased slightly, and you're automatically eligible for a GP card. But again, if there are issues about income being a little bit on the higher side, there's still some discretion there to look at your medical need and to support you there as well. And again, we would support in any way that we can. The drug payment scheme, I think most people are now familiar with. But still, you will sometimes I meet people and it's not something that has been flagged with them. And this is capped at €80 per calendar month per family. So really for your household, and that covers the cost of medicines that are approved, if you have your oxygen or any kind of non-invasive ventilation. And that has been reduced a couple of times over the last couple of years, which is hugely helpful to especially people with oxygen and quite high oxygen needs. And I've added in some links there as well. Get your parking card to help with being able to park in disabled spaces. It actually is really, really useful. You can actually travel nearly all over the world with this card if you're driving. It's €35. It's a one-off. Your GP or ourselves can sign the form, and you get your card back in the post. Really beneficial. I would definitely recommend, if anybody is limited by their breathing, has oxygen, definitely to apply for that. It's actually quite straightforward, and they're incredibly helpful. I won't go through all the bits because it's just telling you about where you can go in the world. It's quite varied. Free travel as well. A lot of people often aren't really aware of it, and about the free travel, the biggest thing about that is that you can apply to have somebody travel with you. So you can nearly automatically apply for your spouse or your cohabitant, but actually you can apply for any adult over 16 to help you with travel, and they would get free travel with you, which is great for people that might have to travel away from home for appointments and things like that, to have a little bit of help. They're based in Sligo, and I've added in all the links that might be useful. And one other resource is your community welfare officer. And this was something I knew about, community welfare officers, but I didn't know the service that they actually provided was so varied and so in depth until a patient told me. And they are in a position to provide extra financial assistance when you apply for it as one-offs. So sometimes people might apply for help with the electricity bill as a one-off and different things like that. But and I've added in a link there on that slide that will bring you to where all the community welfare officers are all over the country. And they provide an amazing service. So they can you can apply for additional needs payments for your bills or for traveling to appointments. You can apply for income support. You can apply for just supplements to meet ongoing needs. And then there's, for anybody that might be renting, you can apply for support with that as well. And then in terms of your home, for housing grants and schemes, so for renovations to your home to make your home easier to manage, to navigate around, there is lots of links in terms of upgrading bathrooms, handrails, lots of different things that you can apply for, and for energy grants for your home as well. And I've added all the links. If anyone has a question that I can't answer on that, I'll find out for you. And then all the other services that are out there, it's amazing, the support that's out there. And I've added in some links, assistance information, threshold if you happen to be a tenant of a home, for your grants, the St. Vincent de Paul, a loan. There's so many wonderful services out there. And I think it's great. I'm really happy to be able to alert people to them being available to help and to offer support. And I talk about them a lot with my patients, and some great things have happened for people. But I suppose the key message is, don't be afraid to look for some help, and don't be afraid to apply for things. Nothing bad is going to happen because you've put in an application form. As we say, the worst they can say is no to something, but it might lead you on to being granted something else that might be useful and really important. And I think by me understanding a little bit about these things, it definitely adds to my role to be able to offer support to all my patients. And that was a whistle-stop tour. I think I'm bang on time, Maureen.
Thank you. Thank you so much, Helen. That was really informative. And we've had some questions come in. Unfortunately, we've run out of time. But what we can do is we can direct message on the questions, if that's okay.
Absolutely.
And I know you're going to share your slides as well.
Absolutely.
And then sharing additional information around entitlements with the patients that are inquiring about them. Yeah?
Yeah, absolutely. No problem at all.
Wonderful. Well, thank you so much. That was really informative.
Thanks so much.
And our last speaker here before we go to a quick little comfort break is Kathleen O'Meara. We had a great day out this week, Kathleen, at the Dáil. Kathleen's a former RTE journalist and a member of Seanad Éireann from 1997 to 2007. Following that, she became head of advocacy and communications at the Irish Cancer Society and served in a similar role in the rehab group. Now, since 2020, Kathleen has been an independent public affairs consultant and strategist, providing advice and advocacy services and training to a range of charities and not-for-profit organizations. She's based in Neenah, County Tipperary, which I hear has everything that you would ever want to have just there. And you're going to give us a quick update on the work that we've been doing.
Great, Maureen. Thanks very much, and great to be here and great to see you all. Can I just clarify before I start, Maureen, when do you want me to stop?
If you could give us 5 minutes, that would be perfect.
5 minutes, grand. So you've given a quick overview of my career. So where I am now is, like, I've been a journalist, I've been a politician, and I've worked in the not-for-profit sector. So in 2020, I set up my own consultancy, my own business, so that I could offer my expertise and my skills and my knowledge to organizations, to not-for-profit organizations, so that organizations like yourselves, like ILFA, you know, could be as influential as you could be and get the change that you want to get in the Irish political system. Now, health in Ireland is actually very political. In case you didn't know this might be news to you. It probably isn't. And in fact, when you look at the lobbying register in Ireland, what you see is that by far and away the biggest area that people lobby on is health. Not going to go into all the ins and outs of that, all my I suppose my ideas on my opinions on why that is. Let's just accept that that is the case. So health in Ireland is very political, and we are a small country, and that's very advantageous from the point of view of an organisation. We are close to our politicians, and our politicians are close to us. And that means that for an organisation like ILFA or many other not-for-profits, many other organisations representing patients in particular, it's really important to use the political system as to your advantage as much as possible to get what you need. Because the fact of the matter is, politicians wait for people to come to them. They don't go out there looking for people who need support from them. There are a lot of people who go to them every day of the week, and they're very, very busy. So if you want them to know about your issues, you have to go to them. And that's what we did last Wednesday. So the Health Committee, the Oireachtas Committee on Health, which is made up of backbenchers from the government, but also members of the opposition, and is always chaired by a member of the opposition. Currently, Sinn Féin is the largest opposition party chair the committee. It's Sean Crowe from Tala. He's the chair. It's made up of TDs and senators from all the political parties, effectively, who make up the Dáil and Seanad at the moment. They are quite an influential committee from the point of view that they highlight issues. The HSE is required to go to them every quarter, so 4 times a year. The Minister for Health also goes to them 4 times a year. So their role, and indeed the role of the other committees, but let's focus on them now, their role is to hold the Minister and the HSE to account. And so in going to the Health Committee and getting on their agenda, we then use them to get our issues in front of the HSE. Now, ILFA has been dealing with the HSE, as we know, and through the clinicians and through the ITS. But we decided that we needed to go to in front of the HSE, in front of the Health Committee, so that they would hear about the issues facing patients with lung fibrosis, members of ILFA. So that's what we did on Wednesday. We wrote to them, and then basically we went in, and one of the members of the committee, who I know in fact, sponsored us, and who came in as well was Nicola and Maureen and myself went in with Michael Dara Macaulay, and Michael Dara, as you know, is a GAA superstar and a royalty, and we got a lot of attention as a result of Michael Dara coming in with us. So that brings me to my next point, which is how powerful you are, both individually and collectively. So it's an election year. I think there will be more than local and European elections this year. I think there'll be a general election this year. So when elections come around, politicians get very, very focused on the voter. Now, they always are, in fairness to them, but they get super focused on the voter in an election year, which means that the voter becomes more powerful in an election year. And that's where each one of you who is a patient or is in the family of a patient, you have a lot of power. You should, if you don't already, find out who the politicians are in your constituency, what constituency you're in, what politicians are in your constituency. Just look up oireachtas.ie, you'll find that's very easy to find. You may know already. And if you haven't had contact with them, please make contact with them. Please build a relationship with your existing politicians. And that means, for example, going to their office usually on a Friday or a Monday, or when they hold clinics. Most politicians hold clinics around the place. Now, some of them, they kind of went by the wayside during COVID, but I think most of them have come back. Ring their office, write to them, look for a meeting. Remember that if you email a politician, doesn't mean you'll get a response. They get hundreds, maybe thousands of emails every week. So you have to follow that up with a phone call. But say who you are, that you are a voter. You're one of their voters. So you're a very, very important person. So, and if you do that, let us know about it. Because as the election comes around, one thing we want to do is make sure that what ILFA wants is in the party manifestos. We're going to be working on that over the next few months. So, you have a role in that as well. So one of the very powerful tools that ILFA has is membership, is you, the members, and you can play a very, very important role. So please, if you wouldn't mind doing this, firstly, is start to think about and exercise the power you have. So reach out to the politicians in your constituency. I'm talking about TDs and senators largely. And if you know people who are going to be running in the general election, all the better. Now, local elections, you can mention this on the doorstep, bring it up on the doorstep. They are councillors. and they don't have any direct responsibility with health. But if they are in a party, for instance, they can bring this issue, bring our issues, your issues, to the attention of the TD in the party which they are running for. And even if they're independent, quite a number of senators now, and indeed some TDs as well, there's quite a number of independent TDs, and they have relationship with councillors as well. So every opportunity you get at a political level, raise your issues, raise our issues, ILFA issues with them. And what we're lobbying for specifically is a clinical care programme, and we are looking for, and we were told on Wednesday that we may get before the committee on the 8th of May. Now, we may get there on the 8th of May. If we do, that's great, because the target is to get in there before the summer recess. So we got a very good hearing on Wednesday. We had a briefing document. We brought the briefing document to all the politicians that we met, both on the committee and not on the committee. And we are also seeking a meeting with the Minister for Health, and some of the politicians have taken on, supporting us in getting that meeting. So it was very, very useful day. Some people say, oh, you shouldn't have to do that, but you do. So that's the beginning, middle, and end of it. You have got to go and meet the politicians, because if you don't go and tell them about your issues, they just won't know about them. It's that simple. So I'll wrap up there, Maureen, because I could see we've gone over the 12 o'clock time, and we should be on a comfort break by now. So I'll leave it at that, and sure, if there's any questions, let me know.
That's wonderful. Thank you, Kathleen. And thank you so much for the work that you're doing with us. It is really making a difference. And I think just in terms of maybe being able to support people in those conversations, it might help them to have a few talking points. So I wonder if that's something that we could be developing and communicating to folks.
Yeah, I mean, we can use the material we had on Wednesday. We can use that material. So we're all on the one page. You know what I mean? We're all on message. Yeah. But our target right now is to get in front of the Health Committee, and yes, it's 8 weeks. It's 8 weeks to the local elections, and so it's a short period of time. And from here on, you can expect a knock on the door, I'd say, from local election candidates. So don't make sure you use the opportunity to bring our issues to them.
Thank you so much, Kathleen. And as you mentioned, next up is a comfort break. And I wonder if we could just maybe do a little bit less than 10 minutes and come back at, 12:10? Would that be okay? We have the next section of our broadcast here with 3 more speakers coming up. First up, we have Sinead Coyle. Sinead is a senior physiotherapist in St. Francis Hospice in Dublin. She graduated as a physiotherapist from the University of Ulster in 2014 and went on to obtain a master's degree in University College Dublin. Sinead works primarily in the outpatient day services in Blanchardstown as a special palliative care physiotherapist. She's been working there since 2020, and she leads the Exhale Pulmonary Rehabilitation Program designed for those with advanced lung disease. You're very welcome, Sinead.
So I'm going to put the timer on, and please do interrupt me if I need to stop. So listen, I'm really glad we have so many people here today to take on this information. This day is for you, and I hope that you take something from these slides today. I'm glad to see the advances in the medications. To date, it's super. But in the meantime, the rest of us have to keep trucking along and managing the ILD, and I suppose my focus today will be on the non-pharmacological side of things, so not medication related. Firstly, to say that I would be completely lost without my colleagues in the hospitals. I wouldn't be able to do what I do without being able to link in with them. So it's a huge part of the success of what we do. I suppose I work with those at the more kind of mid to severe part of their lung disease, but I would say that there's huge value in knowing all the information that we give as early as possible to implement good habits. I work in a hospice. I think some people, when they hear the words palliative care, puts the fear of God into them, but it's an additional service with a focus on quality of life purely because you have an incurable disease. Okay, and I've yet to meet someone who came in the door and went out feeling any worse. They, you know, if anything, they're completely more at ease when they're leaving. So don't ever be afraid, I would say, when you hear that. My goal today is to enable you all to take some control of your condition, because we all know too well that our mindset tells us so often that it isn't in control of us. I'm going to focus on the main symptom, which is breathlessness, but what I want you to know is that breathlessness is indicated, or sorry, it's controlled by, our level of breathlessness is controlled by how we breathe, how we think, and how we function, and how each of these, how we carry out each of these impact on our level of breathlessness. If you were to ask anyone how does it feel like to be breathless, they'll give you a different answer. Okay, I love this picture. It depends on who you ask. Breathlessness is a sensation. Okay, so it's an uncomfortable sensation. It's difficult to breathe. And obviously, if there are changes in your lung, you're going to get breathless easier. But it really goes back to that thinking. So how you process your breathlessness. This athlete isn't going to be too bothered because they know that their breathlessness is because they've pushed themselves really hard in a race, whereas someone with a lung condition is going to say, oh, this is it, my lungs are giving up. So it's really kind of how you think about it really affects how you control it. So of all the people I've met, I asked them, you know, how do they feel when they're breathless? You wouldn't believe the amount of people that tell me that they think that this is it. This is them on the way out, they're going to die. And I know that seems really extreme, and people might not say it outright, but you wouldn't believe how many people actually feel that way. Some people are really embarrassed by their breathing and they try to conceal it, which means that they're actually more breathless as well. And then others just get really panicked, and that's probably for fear of you know, that they're going to have some sort of sudden event. I suppose in relation to that, I would say to you that your thoughts can be really distressing. They can be really frightening, but they're not facts. And although breathlessness is unpleasant and frightening, the actual symptom itself in that moment is not medically harmful. So I have outrightly said to people, you know, this exercise that I'm about to make you do, it's not going to kill you. Okay, so I just want you to be really mindful of how you think when you get breathless. Your thoughts in the past didn't turn out to be true. Okay, you didn't tip over the edge, and you've gone through it before, and you will recover. What does it stop me from doing? You know, so many things, and it's so it can be so disheartening. For some, it can socially isolate them. They go into the pub on, I don't know, if you go 2, 3, 4 nights a week, to all of a sudden having to be sitting at home because you're embarrassed by your breathlessness, or you feel like you can't. Walking the dog, good for the head, but all of a sudden you can't. Going shopping can be really therapeutic, but all of a sudden you can't, or you don't enjoy it. For some people, it's just easier to stay in bed, and I get that. I always say I get it. You know, when you're sedentary, when you're sitting, so often our breathlessness isn't there. So I can see why it's so easy, or it would be the easier option to stay there. I put this lady in running to the toilet because I would say 90% of us delay going to the bathroom because of the dread of getting breathless. Okay, and then we end up rushing. And what does rushing do? It makes us even more breathless. And they're just some of the reasons why people stop what they're doing. It can be embarrassment, it can be oxygen, and it can just be that they're not able. So I suppose this scale, it's technically called the Borg scale of breathlessness, but it's a fancy score of 0 to 10. But what this scale will allow you to do, if you implement it in your life, is it will allow you to control how breathless you get during any activity. I'm not saying you're not going to get breathless, but I'm saying it will be more manageable and you will recover quicker. I suppose when we live with chronic conditions over time, we can gradually, our musculature can change, and we can end up using every muscle to help us to recover. And, we're lifting our shoulders, we're doing everything we can. And it just leads to these muscles getting tight, we're using energy, we're feeling low on energy as a result, and we're really tired because we're overusing these muscles. So one of the things that you will hear about is diaphragmatic breathing. The picture you usually see is one hand on the chest, one hand on the belly. When you breathe in, the belly moves out. When you exhale, the belly falls. This picture just shows you the space that develops in the lungs to take that breath in when you breathe effectively. It's not an easy thing to master. It needs practice. So if you decide to do it in the middle of an episode of breathlessness, it's going to be really difficult. So practice these things, I would say, to be confident, to be able to carry them out so that you feel better, because that's the main aim here. It's all about percentages. None of these things are going to, get rid of your breathlessness or, reduce it by 50, 60%. But even if you do 10 things that reduce your breathlessness by 1 to 2%, that's enough to make a difference and to enable you to do the things that you want to do. The next thing are positions of ease. Again, really simple. But what we're doing here is we're eliminating the need for those shoulders muscles, those neck muscles to overwork. And you'll see athletes in these positions when they're breathless, or you might just do them and not even realize that it's something that has been advised, because that's the way your body finds it easiest to recover. I always used to think when I was playing sport is that our managers always say, put your hands over your head to recover. And I always thought it was madness because it was the most uncomfortable position. Really, you want to relax your shoulders. Pursed lip breathing, again, we probably developed this unknowns to ourselves, but that's that pursing the lips together. Imagine you're flickering a candle or blowing a feather, but it's not forced. And you'll notice here that the exhale is longer than the inhale. So it's 2 in and 4 breaths out, okay? Do what you can. Sometimes when we overthink breathlessness, it can make us more breathless when we're trying to control it. So in the acute phase of that breathlessness, just go with the flow. And then when you feel like you can implement some of these, do, or when you've practiced them, you can implement them. This rectangular breathing is just a nice way to do the pursed lip breathing. There's rectangles everywhere we look around. So the short side of a rectangle is the breath in, the breath out is on the long side. And all we're doing really is we're switching our focus to something that's not telling us, oh, I'm on the way out here because I'm breathless. We're focusing on rectangles and feathers and candles instead. Fans can be nice because often we're looking for that gush of air that we just can't find and we want to stick our hand out a window. A fan is something similar and you're just holding it below your face to blow up to give you that sensation of breath. When you are in that acute stage of breathlessness, you are at that not where on the Borg scale you want to be 4 to 5, you're gone beyond that, okay? But you will recover if you stop, because doesn't breathlessness go away if we stop what we're doing and sit down and get into a good position, focus on the breath out, open a window. I was watching a race the other day on YouTube, and it was the end of 3,000 meter race, and I was looking at the athletes when they crossed the line, and aren't they implementing everything that we're telling you to implement? This lad at the top has certainly flopped and let go, but their thought process is just different, so that's why they're not worried, because they know they'll recover. So I want you to just get into the mindset that you will recover too. I suppose the most important part of this then is the functioning. So how you function. As I said earlier, it's easier to decide that you're going to be sedentary or that you're going to sit because we don't get breathless when we're sitting. But it's a vicious circle in that we become fearful of breathless. We avoid the activities that make us breathless. We do less. The muscles become weaker, and then we are breathless because we're fighting weakness as well as a lung condition. So we're looking to break the cycle here. And as difficult as it can feel, and don't judge yourself as being lazy. I hear that so often. I'm lazy. You're not lazy. It's just so much more difficult for you to exercise than anyone else. So it's easy for us to stand up and say, do this, do that. But we know how difficult it is for you. But if you can just take one step in the direction of being a little bit more active, you're doing something really positive. I work in a palliative care setting. I can tell you now, my own colleagues think I'm crazy when I tell them that I'm getting so-and-so to do an exercise class. And I think sometimes patients themselves are surprised because they're able to do what I asked them to do. But that's because we've chosen something that's appropriate for them. Never compare yourself to the person sitting next to you, because how they breathe might be different and how they think might be different. And that's why they might manage a little bit better. Okay, but just focus on yourself and what you can do. And anything is a good thing. You want to be again at that level of 4 to 5. You're still able to talk. You shouldn't be like this. Okay, that means you've gone too far and your breathlessness it's going to take longer to recover, and you're going to enter that phase where you're frightened, and we don't want that. So we want you doing enough to make a difference, but not enough to scare you off. One step in the first step of the stairs. Okay, you don't have to see the whole staircase to take the first step, and I love that. The recommendations technically are 30 minutes a day, 5 times a week. Most of us will look at that and say, is she mad in the head? Okay, but just do something. Do a little bit of aerobic where the heart rate is going, your breathlessness is up. Muscle strength, 2 tins of beans, 2 bottles of water, hands over the head. So easy, but put it into your daily routine because we won't do it otherwise. And we'll avoid it for as long as we can because it's difficult. Some little tips just in relation to some of the more difficult tasks. The stairs, okay, can be Mount Everest for some people, but most of us stand at the bottom, look up at the top and say, right, let's get this over and done with, and fly up the stairs and can't even speak at the top. So I would suggest to you to break the stairs up into 2, break it up into 4, but never pass that 4 to 5 on the Borg scale. Okay, consider a second handrail. Take more breaks. Showering is another thing that people dread. Can be really claustrophobic. Reduce the temperature of your water. Wear your oxygen. Some people don't think they can, but you can. Sit down if you need to. Get a chair. And then when you get out of the shower, wrap yourself in a towel and sit on your bed and let the towel do the work. Okay? Little mention on oxygen. Not everyone who's breathless needs it. Oxygen treats what we call hypoxia, which is reduced oxygen saturations, but it's not necessarily going to take all of your breathlessness away, okay? And so often I see people coming into me with the little monitors and they're checking them so often. And if you're wearing nail varnish or your hands are cold, that can affect the readings. So you could be sitting there absolutely fine, check it to see how you're getting on, and all of a sudden you're in the 70s and 80s. And if you weren't panicked before, you're panicked now, okay? Most of the time we'll know where we're at, okay? Think of that Borg scale, okay? Use that a little bit more and use the monitors a little bit less, because they can contribute to that panic that we feel when we're breathless. Ask for help as well. Like, there are ways to best use the oxygen, so do ask for help from those that can. I suppose some of the things I touched on are just tools for the toolbox. We're not going to cure well, I'm not anyway. going to cure the lung disease, but we have little tools to help us along the way, and implement them and make them a habit early on, so that you're in control of this lung disease. Welcome to any questions, and thanks so much for your time.
That was really, really informative. Thank you so much, Sinead. We have one question coming in on the exercise classes, because ILFA has our exercise classes that we do every week, right?
Yeah.
And those are on, maybe Gemma can help me here, or Sinead, if you know.
The exercise class are on Monday, Wednesday, and Thursday for 1 hour.
Perfect. And if you want to register for the exercise class, Gemma?
So you can just call us, call Anne or me on the phone numbers that are the main phone numbers, and you could just register by phone.
Thank you so much for that. And thank you, Sinead. That was all incredibly interesting, but the part on that cycle, the exercise cycle, and it being led by fear, that was incredibly powerful. Thank you. Our next speaker up that we have is Louisa Power. Louisa is a registered pharmacist and currently works as a medication safety specialist pharmacist with the National Quality and Patient Safety Directorate of the HSE. Louisa's worked in hospital and community pharmacy up to chief pharmacist level in public and private hospitals in Ireland and the UK. Louisa's also worked in the area of regulation as a medicines management inspector with HIQA. Louisa sits on the expert task force to support the expansion of the role of pharmacists in Ireland and the Council of Pharmaceutical Society of Ireland, the pharmacy regulator. You are very welcome, Louisa.
No, thank you so much, Maureen. And I just want to wish you the best of luck in your new role. And I just want to thank everyone who has attended this morning, and also just to thank ILFA for asking me to come and present today. I always love coming out and speaking about medication safety. So I suppose just to give everyone a bit of expectation in relation to this presentation, I'm not going to go into the individual medicines that are used for lung fibrosis, but I'm going to go into the practicalities and the generalities around medication safety, so that at least then, people who are on different medicines, it'll be relevant to them. So what I want to cover today is I want to talk a little bit about No Check Ask and the My Medicines list, which is work that we're doing in the National Medication Safety Programme, and around the 5 moments of medication safety. And then I want to talk a little bit about Gordon, who is a patient advocate that we have working with us on the programme, and I suppose his experiences of using these tools. I then want to signpost a really good resource that's available online from the HSE, which is Medicines A to Z, and then I want to go into the top tips for medication safety as well, because as the little picture says, we all have a role to play in medication safety, and I really believe that those who are using our health service, our patients, our service users, are actually key to medication safety. You're the people that are taking medicines every day of the week. You're the people that often recognise that there might have been a mistake made. You're the people who are, as active partners with us as healthcare professionals, are often those who we really rely on to promote medication safety. Justin, can you go on to the next slide for me, please? So what I want to do now is I want to cover No Check Ask and the My Medicines list. So next slide, Justin. So what is No Check Ask? So No Check Ask actually comes from the WHO, the World Health Organization, and it was a medication safety campaign that was developed to support their 3rd Global Patient Safety Challenge, Medication Without Harm. Because what happened was the WHO realized that because medication is often, the most used healthcare resource, it's very important that we try to utilize this particular resource safely. And the aim of the campaign was to encourage anyone who takes medicines and those that provide them with care, either formally or informally, to take an active role in managing their medicines. And really it asks 3 questions. Do you know your medicines? Do you keep a list? And can you describe and discuss your medicines when you want to? So the next slide, please, Justin. So here we go. So we've simplified it down a little bit. What we're saying in the HSE is we want people to know their medicines and, very importantly, keep a list, to check that you're using the right medicine in the right way, and to ask your healthcare professional if you're unsure. As healthcare professionals, we really want people to be able to ask us questions. You know, sometimes we might seem a little bit busy, or you might think, oh goodness, I'm going into the pharmacy and, you know, they're very, very busy, or I'm going into the GP and I've got a very limited amount of time. But we really want you to ask questions. I work a little bit in community pharmacy, and I suppose I'm always delighted when someone, you know, when one of the girls comes in from the front and says, Louisa, someone wants to ask you a question about their medicines, because that then is when we know that people are engaged and are interested around their medicines. So next slide, Justin. So when we asked people to keep a list, what was coming back to us was in the HSE that people were saying, well, how do we keep a list, or what's the best way to keep a list? And really what we want is, we just want anyone to keep a list. But in order, I suppose, to facilitate people to be able to keep a list, we've actually developed the HSE's My Medicines list. And because by having an up-to-date written or printed list of your medicines, it'll help you when you might not remember your medicines. So for example, at an appointment or an emergency, all of us have been in that situation where you've arrived unexpectedly to the hospital, or you're in an appointment and you're being asked to remember your medicines, because unfortunately the systems within the healthcare system don't all link together. So your GP might have a list, your pharmacist might have a list, but often maybe the hospital doesn't have the list, or the consultant doesn't have the list, or the dentist doesn't have the list. And the My Medicines list forms part of our response to the No Check Ask campaign. And really what we wanted to do was to provide a list of key information about all of your medicines on one page. So there on the right hand side, you can see what the My Medicines list looks like. We have professionally printed copies of these, and they're printed front and back on one page, so that it's, you know, it's easy, it's portable, you're able to take it with you. So everyone who takes regular medicines is encouraged to keep an up-to-date self-compiled list. And self-compiled is really important. This is your list. This is the list that you have created yourself. It's not a list that comes from the pharmacy. It's not a list that comes from the GP, because often you're taking your medicines maybe slightly differently to what maybe the GP is aware of. There may have been changes in the hospital that your community pharmacy may not be aware of. So, and there also might be other medicines that you're taking. So you might be taking herbal medicines, you might be buying things over the counter. So it's really important that this list is your list. It's a self-compiled list of your current medications, and that you take this list with you to all healthcare appointments. So next slide, please, Justin. So a question that I get asked all the time is, well, how do I fill in a My Medicines list? Where do I get this template? Now, some people, you may have actually received maybe something like this when you go to a hospital appointment. I know that some hospitals in Galway and also in Limerick actually send out the My Medicines list template with some of their outpatient appointment letters. Some people, you may have seen it in the community pharmacy. They might have it up in the health information section of the pharmacy where they have all the lovely leaflets, or your GP might have them displayed as well. But we actually have the template available to be downloaded online from our website. At the moment, it's available in English and some other languages, but what we're doing this year is we're going to extend out those languages for which the My Medicines list is available, so that it's accessible to as many people as possible. Before you fill out the My Medicines list, make sure you've got all of your medicines in front of you, and include medicines that you take regularly, and also those that you take occasionally as well, because you may be on an injection for your bones that you only take every 6 months. You may be on a patch that you change every week. So it's important that all of those medicines, not just those medicines that you take every day, are included. And every medicine counts. So prescription medicine, so please don't forget any inhalers, any patches, injections, creams, eye drops, and any other prescribed products. You can include the strength of the medicine, how many you take each day, and it's really important as well maybe to put in the time of day, because if you're on a very specific regimen, where you're taking maybe certain medicines in the morning and you might have to take some again at lunchtime, it's really important that we know about that. Always include as well any over-the-counter medicines that you're buying, any vitamins and supplements, and also herbal, homeopathic and alternative medicines as well. And on the My Medicines list, we have a space where you can record any allergies or any sensitivities that you have, and also very importantly, the contact numbers of your family doctor and pharmacist as well, so that information is available for those in the hospital or in outpatients. So the next slide, please, Justin. So some tips and tools. We introduced the My Medicines list a number of years ago, and through talking to patients and groups, we've actually picked up a few tips and tools that we like to share with people. So some people, because I suppose the paper list now, it might be difficult to carry around. Your purse or your wallet mightn't be big enough to hold it. Some people find it useful to keep a photo of the list on their phone. or maybe to take a photo of the medicines with their labels in full view. Now, I find this is particularly difficult if you're on more than maybe 4 or 5 medicines, because it's hard to fit all of those medicines into a photo, and also to get the photo clear enough that you can see the labels. But by being able to have the photo of the list, you'll be able to share that list with a family member or carer. You'll be able to send that maybe by text message, by email, or one of those WhatsApp or one of those other messaging services. It's really important to bring the list with you when you're attending any healthcare appointment, because as I said, a lot of our systems in the health service, a lot of our IT systems in the health service, they don't link up just yet. So we may not have that particular information. If you've got any changes to your medicines, I always say to people, ask your doctor, pharmacist or nurse to explain those changes to you so you're clear. You know, is it that a medicine now has to stop because this particular medicine has been added in? Is it that this medicine, you know, how long are you going to be taking this medicine for? Is it for long term? Is it for short term? And what is this new medicine for? Or why has a particular medicine being stopped? Because that's really important information for you to have. Because as I said, a lot of the healthcare system, IT systems don't link up. So by you having that particular information, it's often helpful for other members of the team. And it's really important to keep the list up to date, so you can add any new medicines to the list or drawing a line through any medicines that you no longer take. But if the list is starting to look a little bit messy, maybe you've been in hospital for a couple of days or a couple of weeks and there's been a lot of changes to your medicines, it might just be best to start a new list all over again. Next slide, please, Justin. So I also wanted to talk a little bit about the WHO 5 moments for medication safety. The World Health Organization loves 5 moments. So some of you who might have been in hospital, you might see with that up, there might be 5. If you've been sitting in waiting rooms, which I'm sure a lot of you have been, you might see the 5 moments of hand hygiene, the 5 moments of infection prevention and control. So the WHO also love 5 moments for medication safety. And we have these resources available to print off, and they are handy to bring with you to a hospital appointment, because what the 5 moments do is it sets out questions that you can ask, you know, when a medicine is being started, that you might be able to say to yourself when you're taking a medicine, if a medicine is being added, if a medicine is being reviewed, and again, if a medicine is being stopped, so that you are in control in relation to your medicine. So you understand why a new medicine has been started, you'll understand why a medicine might have been stopped, and also the reason why medicines are being added. Because I think sometimes what happens is we go into appointments, I've been there myself, there's a lot of anxiety, the consultant is saying we're going to start a new medicine now, and you leave and you think, oh my goodness, I should have asked, what's that medicine for? What are the side effects going to be? Is it going to interfere with any of my medication? So this particular leaflet, which is available to print off on our website, is actually quite useful if you are going to any appointments. Next slide, please, Justin. So I wanted to talk a little bit about Gordon. So Gordon is one of our patient advocates, and Gordon is somebody who developed a serious illness later on in life. And these are all Gordon's words. And I think it's really powerful to share these words, because I think it really just shows how by taking control of your medicines and by being empowered and by asking questions, how we can actually be how we can actually get the most out of our medicines. So what Gordon would have said is that all he ever wanted was to live a normal life, and he never thought that daily medication would have featured in that. And during the initial years after his diagnosis, he really struggled massively to accept his situation. And the truth be told, he simply just didn't want to know. But eventually the penny dropped, and he fully familiarized himself with all the medicines that he was taking and why. And for the first time, he felt actively engaged and was taking responsibility for his medication regime. And his medication regime would have been very, very complex. But he felt like he was in the driving seat in terms of his condition. Next slide, Justin, please. So what Gordon says is that it's crucial that we as healthcare professionals consistently support you, patients, and their caregivers in this way. Their role in encouraging patients is absolutely invaluable, and by keeping a list, you can show this to staff at your appointments and ensure that you're using your medicines in the right way. And what's really important, and this is why we've highlighted this, is Gordon says that you have the power and the responsibility to yourself as a person taking medication. So just a next slide, please. And I suppose this very nicely links into the HSE medicines A to Z, because often when I'm working in practice, people say to me, oh, I looked online and I saw this about my medicines, or I looked online and I saw that about my medicines. And it's really difficult. I know myself, even, you know, when I'm looking stuff up, a lot of the information that's available online, it's very difficult to figure out, is it reliable? Is it reputable? Can I trust it? And the HSE, in response to that, have developed, and we're in the process of developing what's known as the medicines A to Z. So at the moment, what we have is we've got the top 50 most commonly prescribed medicines in alphabetical order. And it's basic guides on medicines, their common uses, their side effects, their dose, their duration of treatment. And it's developed by health experts. So ourselves in Safer Meds, we also have a prescriber, and we've got the Health Products Regulatory Authority are also involved in this. And if your medicine is not on that list, we do provide links to information on accessing patient information leaflets. And we've got a little bit more funding this year, so we're hoping that more development will come shortly. And I've got the link to the HSE Medicines A to Z, and I'd encourage you to use that. So now we'll do a very quick whistle stop tour of top tips for medication safety. So all of you who are taking prescription medicines, you'll know that the dose instructions are on the pharmacy label. But if you buy a medicine over the counter, the instructions are often on the back of the packet. And it's really important to never take a medicine that was prescribed for somebody else, because it might not be safe for you, and not to share your medicines with anyone else. All of your medicines will come with a package leaflet. And I always say it's important to read this information, as it does help you to make sure that the medicine is right for you. And the package leaflet will tell you about any special instructions for your medicine. It'll also tell you if there's any side effects you should look out for, and what you should do if you think you have a side effect. And I'm going to go into side effects in a little bit more detail in another slide. If you do get your medicine and it doesn't have a package leaflet, just ask your pharmacist for one. And if you have any questions about how to use your medicine, or after reading the patient information leaflet, you've got any questions, please ask your doctor, pharmacist, or nurse. Next slide, Justin, please. So I suppose what I really wanted to cover in a little bit of detail are interactions and side effects, because I suppose many of you are on quite a lot of medicines and might be concerned, you know, about interactions or how medicines might interfere with each other. And I suppose we know that medicines will react with medicines, supplements, foods, and drinks. And taking a medicine may worsen an existing health condition. So, for example, some cold and flu remedies that you buy over the counter can increase blood pressure. And interactions can affect how your medicines work, or it could actually cause more unwanted side effects. So some alerts for interactions might appear on the dispensing label. So on the label on the little pharmacy label. So you might have seen with some medicines, it might say to avoid grapefruit juice, but then there might be more information on interactions included in the package leaflet. So that's why the My Medicines list is really important, because by having the My Medicines list, you can actually make sure that your doctor, dentist, nurse, or pharmacist knows about all of your medicines before a new medicine is started. And it's really important as well to ask your pharmacist, doctor, or nurse for advice before starting a non-prescription medicine or supplement. So if you do need to buy something over the counter, maybe for your cold, for a flu, for a cough, make sure you check with the pharmacist, you know, before purchasing that particular product. And as I said, again, if you read the package leaflet and you're a little bit concerned about anything, always ask your healthcare professional, whether that's your doctor, pharmacist, or nurse. Next slide, Justin, please. Now, side effects, I suppose side effects are is something unwanted or unintended after taking a medicine. And again, the information about the possible side effects are on the package leaflet, and may include the chances of developing that side effect. So it might talk about things being common, uncommon, rare, and blood tests may be required as well to monitor for some side effects. You might be aware that your GP will have to maybe be monitoring your liver or your kidney function, just to make sure that that medicine is not affecting your liver or your kidney function. Many side effects are mild, and you can actually continue taking the medicine. So some things like, you know, mild nausea, diarrhea, sun sensitivity, we can actually manage. Or we might have to maybe reduce the dose a little bit so that we can actually alleviate or try and manage some of those symptoms. However, for some people, the side effect might be quite serious and the medicine might need to be stopped. Again, as I always say, if you're ever worried about a side effect or about any information that you read in the package leaflet, talk to your doctor, pharmacist, or nurse. The Health Products Regulatory Authority in Ireland, they're the people who are responsible for the safety of medicines in Ireland. They encourage the reporting of side effects so that the safety of medicines can be monitored. And they said that, you know, they actually encourage reporting, not just from doctors, pharmacists, or nurses, but that members of the public can also report side effects. And it's quite easy to report a side effect to the HPRA. You can complete an online reporting form, you can print a form from their website, or you can actually telephone them and they will go through the reporting form with you online. Just the next slide, please. I just wanted to mention a little bit about generic medicines, because I think over the last few years, many people, have become concerned because they're seeing maybe more and more generic medicines. And it's really important to be aware that if you are taking that if you are getting a box that might look a little bit different to the box that you've had before, that you ask your pharmacist. So with Lipitor, that would have been the branded product. The active ingredient is atorvastatin, but you now might be getting, another generic brand, but it still contains atorvastatin. And I suppose that is the most important thing to remember is, that particular medicine is still exactly the same medicine. And often these particular medicines are made in Ireland. So we're encouraging, I suppose, our local economy. The same with things like Proteum. Pantoprazole would have been the generic name, but some of the medicines might actually have what we call a branded generic. So Protazole will be a branded generic. So it's basically that the company has put a brand on their particular generic medicine. But again, it's really important that, as you ask your pharmacist if you're unsure, because again, we always are really happy to try and help you with your medicines. Next slide, Justin, please. So we're here at the very end. So as I said, really the take-home messages is know your medicines and keep an up-to-date list. You can download the list from our website. Check that you're using the right medicine in the right way, and always ask your healthcare professional if you're unsure. Always try and use reliable and trustworthy websites for medicines information, like the HSE Medicines A to Z. Make sure you let your doctor, dentist, nurse or pharmacist know about all of your medicines before a new medicine is started, and use the My Medicines list. And then if you need to start a non-prescription medicine or supplement, always seek any advice from your pharmacist, doctor or nurse. And if you're worried about a side effect, again, talk to your doctor, pharmacist or nurse. As I said, really the main take-home message here is, as healthcare professionals, we welcome your questions, we welcome your engagement, and please don't be afraid to ask any questions. Thank you very much, Maureen. I'd say I've gone over time there.
No, you're great. Thank you so much, Louisa. And the My Medications list, that is the important thing that I've
Yes.
learned here. Rory also has mentioned in the chat there, he's saying that a lot of smartphones have a health section where you can record your medications as well. So if you're tech savvy, there's an opportunity for you there to record it on your phone.
Absolutely, Maureen. And there's a patient app coming from the HSE in the next 12 to 18 months. So we'll be incorporating the My Medicines list onto that as well. So that'll be even better again.
Wonderful. Oh, technology.
Wonderful.
It's a great thing.
Technology
Thank you so
great.
much.
Thank you.
Our last speaker here before our break is Dr. Roisin Cahalan. Roisin is an associate professor of physiotherapy at the University of Limerick. Prior to joining UL in 2013, she worked in a range of private and public settings, including rotations at the University Hospital Limerick. Her research interests include improving the health and wellness of people with chronic respiratory diseases such as COPD and pulmonary fibrosis. She founded and she leads Sing Strong, which is an online in-person singing program with Miss Kira Mead, a vocal coach and community musician who's also from Limerick. Roisin was delighted to be awarded with an IRC New Foundations Award in 2023, along with ILFA, to study various exercise interventions for people with pulmonary fibrosis. You are very welcome, Dr. Cahalan.
Thank you. Can you hear me okay there?
Sure can.
Great. Thank you, Maureen. Good afternoon, everybody. I'm Roisin Cahalan. Maureen's already done the introduction, so I'll skip right along. I'm here to talk today about Build 2K, which stands for Body Walking in ILD. And as Maureen said, this was a joint venture between myself and ILFA, and we were really happy to be funded by the Irish Research Council. And I'd like to really thank Gemma and ILFA and everybody for having me here today to talk about it. In particular, I'd like to acknowledge the work of Nicola and wish her the very best now that she's stepped down. And she really, along with the board in ILFA, they were the brains behind this idea. So Build 2K really is based on building on the 2000 Steps project or program that you guys are all familiar with. So that's the 2K part of it. And the build is body walking in ILD. And it's really for anybody with any sort of pulmonary fibrosis or any interstitial lung disease. And the idea behind it is that we all know exercise is so important. It's, it's the gold standard of conservative management for people with lung fibrosis, and really helps all aspects of our lives in terms of our physical and our psychosocial health. But for all of us, exercise can be hard to keep going, hard to find the motivation. And the idea was, if we were to exercise with somebody else, with a body, that might increase our accountability, our motivation, our confidence to exercise a little bit more. So we have spent a good bit of time in exploring how we're going to design this project. So I've spent some time talking to some fantastic clinicians in the Mater and in University Hospital Limerick, and also to lots of patients who have various forms of fibrosis and their family members. And a big shout out to the Kerry ILFA group down there in Tralee, who were fantastic to talk to me. And based on all of that information, we've put together this 10-week program of body walking. So it's going to hopefully kick off recruitment next month and happen over the summer, because we're all going to have a fabulous, glorious, sunny summer in Ireland this year. So just into the nuts and bolts of it, there are basically 3 types of bodies that you might be able to choose from. So the first one is, you might be paired with somebody in your locality or in your town or your village who has a similar presentation to yourself, in that functionally you guys would be similar, that you'd walk the same amount of steps, or you'd have the similar exercise capacity. So that would be option 1. Option 2 would be that you would walk with a family member or a friend who wouldn't necessarily need to have fibrosis. And the third option, which seems to be the most viable, according to everybody that I've spoken to, would be a virtual body. And this would mean that you'd be connected with somebody via WhatsApp, and you guys would check in with each other every day to say, okay, I've done my walk today. How are you? Are you getting on okay? Are you going to do your walk? And it really encourages a little bit of accountability, because I don't know if you're like me, but if somebody says, come on, we agreed we'll go for a walk, you can't kind of say, right, I'm not going to do it today, and just bow out because you feel a bit lazy. So it's about that accountability, and it's about maybe having somebody else to give you a bit of encouragement and support and motivation. So how it's going to work is that we're going to reach out to recruit people. I'm looking for 40 buddies, so 20 pairs of buddies. You can be from anywhere in the country, so long as you're over 18 and you're clinically stable outside of your condition, so that you're relatively well. It doesn't matter if you're on oxygen. It doesn't matter if you exercise inside. We're going to pair you up with somebody who's very like you. So the first thing we'll do once we recruit, and I'll talk about that in 1 second, is we're going to have a workshop online, probably something like this via Zoom, where we'll talk about all the different guidelines. So there's, we'll talk about some safety parameters. We'll talk about just some of the guidelines in terms of how hard you should be pushing yourself, those kind of things, guidelines around what kind of information will be shared on WhatsApp. And then there'll be a meet and greet with your buddy. So we were jokingly saying it would be kind of like speed dating for your buddy. So you get to know the person that you'll be working with. And then you'll be given a little document. I don't really have a page of it here, but it's just a 1-page document that will go on your fridge, and it'll have 10 squares for each of the weeks in the program, where you'll record daily the amount of activity you did and the level at which you exercise. So we have the Borg scale here. So we want you to exercise kind of moderate, light to moderate activity. So you're not overextending yourself, but you're still working hard enough to get a little bit of a benefit out of the exercise. So the first 2 weeks of the program, you're going to walk by yourself or do your normal activity. So that can be our baseline. And then the next 8 weeks, you'll walk with your buddy. And I'll collect that information at the end, and we'll see how you got on before and after. You'll be provided with a pedometer if you need one, but most people that I've been speaking to said they either use a fitness tracker, something like a Fitbit or a watch, or their phone. So it's up to yourself. And really that's all that's involved in it. There'll be plenty of communication over and back as we go. In terms of recruitment, I'll be sending all the information via ILFA to distribute out to everybody. You can also contact me directly. So roisin.cahalan@ul.ie, but Gemma will have my contact details as well. I'll be sending recruitment packs to the Mater, to the guys up there who've helped me create this project and how we're going to do it. And they'll be able to send those out to their members, and the same with UHL down here in Limerick. So any clinicians that are on the call, or any patient groups, or any patients individually, if you're interested, or you think your members would be interested, just drop me a line and we'll add you into the participant group. So hopefully, as I said, we're just finalising ethics at that at the minute. It's in for consideration. So we should be starting recruitment next month. And the final thing that we will do, that we've been funded for, is we're going to do a short video afterwards. Oh, sorry, I skipped one thing. After the 10 weeks, we'll do a focus group. So we'll ask select people from the trial to give me their thoughts on whether it was good, whether it was bad, what did they like more and less, so we can, if it's successful, that we can kind of develop this more and roll it out. And the IRC have given us money to create a video. So we're going to hopefully invite some of the ILFA team and some of the patients who've been involved in it, or the participants, to talk about their experience. So there's an opportunity for global stardom associated with this clearly as well. So that's pretty much everything. If anybody's any questions, delighted to take them. Otherwise, I know we're tight on time. That's my contact details. You'll be hearing loads from ILFA about the project. And once again, thanks to everybody. Best of luck, Maureen, in your new role. I look forward to working with you. And thanks to everybody who's attended today.
Thank you so much for that. You know, I was just thinking, my walking buddy, can walking buddies have 4 legs? Because the one that holds me accountable every day is my dog Max.
It may be difficult unless they can use WhatsApp in case of a virtual thing, but maybe your canine friend's very, very clever. But
he's a smart dog. Not
there's ways and means.
Thank you so much for that. Okay, let us take a break, and if it's okay, because we're running just a tiny bit behind, if we could take a shorter break again and come back maybe at 1:05. Hopefully that is okay. See you back here in a few minutes. Thank you. Just to say, we have a few more speakers here today. There was a question that came in during the break asking if we were going to be discussing diet and nutrition today or mental health supports. That's not on the agenda for today. However, that's a great idea for a future agenda. And if there's any specific questions that you have related to those topics, you can pop them in to the chat window and we can answer them as either today or following on. So our next speakers, so we have 2 speakers that are going to come here, and we've got Professor Killian Hurley, is a respiratory physician at Beaumont Hospital and an associate professor in the Royal College of Surgeons in Ireland. His clinical research focuses on the genetic causes of pulmonary fibrosis. In 2019, he was awarded a Health Research Board Emerging Clinical Scientist Award to determine the clinical outcomes of patients with familial pulmonary fibrosis. His lab is interested in finding new treatments for patients with pulmonary fibrosis and uses a patient-derived induced pluripotent stem cells to model disease in the dish. In 2022, he was awarded a prestigious European Research Council starting grant to develop new gene therapies for patients with pulmonary fibrosis. And he's here with Dr. Aoife Cahalan. Dr. Cahalan is a trainee on the Higher Specialist Training Program in Respiratory Medicine. She's currently undertaking her medical doctorate at the Royal College of Surgeons in Ireland with Professor Hurley's group, where she is the Pulmonary Fibrosis Fellow. Her MD research project aims to understand better the behavior and progression of familial pulmonary fibrosis compared to idiopathic pulmonary fibrosis. It will also look at the genetics of the pulmonary fibrosis. So, doctors, you are very welcome to our webcast today.
Great. Thank you, Maureen. Can you hear me okay?
Yep, sure can.
Great. And can I congratulate you on your recent appointment as the CEO of ILFA? I really look forward to working along with you over the coming years. It's a really exciting time for the charity and actually for pulmonary fibrosis patients in general. So congratulations. I'll see if I can start to share my screen here. So I am going to speak. I'm also going to introduce Aoife, who is here with us as well. And let me see, can you see my screen?
We can. Can you put the slides in presentation mode for us?
Absolutely.
That's perfect.
Great. Yeah, so over the next 10 minutes or so, I'm just going to talk about our research in the Royal College of Surgeons in Ireland and across Ireland broadly. I hope you're all well caffeinated now after your little break and eager, and please think about some questions. I really want to hear those questions and see if I can answer them. And I'm going to talk a little bit about science. I really enjoy talking about science and research, but let me know how I'm going. If you think I'm overcomplicating things, let me know. I'm trying to give you my impression of the research And I want people to try and understand this as well, because I think it'll make real impact for patients today and in the coming years. Okay, so I will start by just introducing the people, because while I'm giving the talk, many people have done the research that have produced this research. And so firstly, I'm going to talk a little bit about Aoife Cahalan, who's the clinical research fellow, and she's recruiting patients to clinical research. So that's research that involves taking samples and talking to patients and following them over a year. I'm going to mention Jisa Jasmine, who is a PhD scholar with us and is a bioinformatician and looks at the genetics of pulmonary fibrosis. I'm going to briefly mention Mario Zaki and Anya Schweikart, who work in my lab and have some really exciting projects in the lab looking for new treatments for pulmonary fibrosis and trying to understand what's driving fibrosis. Right, so what is pulmonary fibrosis? Eoin Judge earlier told us a little bit about it, but I just want to remind people. So when we talk about fibrosis, we're thinking about scarring of the lungs, so damage to lungs. The most common one is idiopathic pulmonary fibrosis, and many of you that are tuned in may have that type. But there is also fibrosis from other types of fibrosis from different causes. What causes it is a little unknown really at the moment. So there's some theories. It could be early aging of the lungs. It could be just the repair is not happening properly, but there is scarring down at the level of the lungs where the oxygen is exchanged, and that results in the lungs, particularly at the bottom, becomes stiff. And many people describe it as like the bellows, like that the air is just not able to get out of the lungs. And that means that the lungs don't take up oxygen efficiently, and that can lead to low oxygen levels in the blood. So sometimes we can identify a cause. So there could be a medication that might have caused fibrosis, radiation therapy, mold, or exposure to different types of dust, autoimmune diseases such as rheumatoid arthritis. And if there's no direct cause identified, then we call it idiopathic pulmonary fibrosis, and we all kind of know that as IPF. But we are starting to understand really over the last 5 to 10 years that genes that we inherit from our parents can cause or contribute to pulmonary fibrosis. And over the next little while, I was going to try and explain that to everybody who's joined today. So what is the role of genes in pulmonary fibrosis? So let's talk about what that kind of means. So there's a new term that we tend to talk about now is a familial pulmonary fibrosis. That's a patient or a person that has fibrosis, but they also have one or more family members who also has fibrosis. So worldwide, we think about 10 to 20% of people who have IPF also have a family member with fibrosis. In Ireland, from the Irish Thoracic Society IPF registry, it's about 18%. So it's on the higher end of that range. So about 1 in 5 people with fibrosis have a gene that may be causative or has a family history, at least has a family history. There's 2 different types of genes that I'm going to talk about today. So there's genes that put you at risk or increase your risk of getting IPF or a different type of fibrosis, but they don't directly cause it. So you have to have the gene and then be exposed to something in the environment over those years. The most common and the strongest risk gene that we know of is one called MUC5B. I'm going to talk a little bit about that. In the European or Caucasian population, that's about 10% of people walking around everywhere. Just normal people have that gene. So not 10% of people have fibrosis. So it puts you at risk, but doesn't cause it. And it's an important one. I'm going to talk a little bit about it. There's also these rare genes that can directly cause fibrosis, and they're very truly rare. Less than 5 or per 100,000 people, and I'll speak a little bit about those. So where can we find out more information about genetics in Ireland? I think this is a really fascinating study, and anyone's interested in the genetics or ancestry and genealogy generally will be interested in this. So working with Professor Giampiero Cavalieri. So Giampiero is this really interesting atlas or DNA or genes from people all around the country. So to get into the study, it's quite special. Your grandparents, all of them, have to have been born within the same 50 kilometers of each other. So that kind of locates your ancestry to one place in Ireland. And then we can look at the genes that are coming from that place in Ireland. We compare it one area to the other. And they've also looked at this kind of clustering. So kind of similar people, what do they look like over Ireland and across the UK as well? And you can see in this picture, there's like little colors and little dots. These are clusters of people who have the same type of genes, and the same colors are those same type of people. So you can see, and I'll just highlight Ireland for us. Just if you, sorry, I'll just go back. Just if you just said Ireland, and it kind of roughly corresponds to the provinces of Ireland. So the same genes and same ancestry is across Ireland. And so what is the rate? We asked the question, what is this risk allele? How many people have this risk allele across Ireland? Because no one's ever looked at this before. And we found it's a little bit higher than what we would expect. It's about 12.4% of people in Ireland have this MUC5B gene, but it's not equal across the country. And we're gonna look at this in a few different ways. So if you look at it at a county basis, so I like to think of this as the GAA way of looking at it. So as a per county, and we don't have data for some of those data points. It seems to be more common in the western counties of Ireland. And we have more numbers and better ways if we look at it per province. And I kind of like to think about that as the rugby way of looking at it. So it's per province. If you look at the percentage ways, you can see there's a higher percentage of people who have this gene in Connacht, in Ulster, and there's a lower level in Leinster and Munster. And this seems to correspond to those different population clusters I was talking about from this DNA atlas from Connacht, Ulster, and Munster. And I would say also in Ulster, most of that MUC5B gene is actually from Western Ulster, which is over in Donegal and the West in Derry as well. So it seems like Irish people have a higher rate of this MUC5B gene in the population. So that's people without fibrosis. But what does the MUC5B gene look like when you look for it in patients who have IPF? And ILFA helped with the study and coordinated with our 3 groups across Ireland. And there was recruitment. This is before I started the study, but I was able to get some of the data from David Schwartz in the US, 236 patients. And we looked at who those people are in terms of their age, their gender, and how severe their fibrosis was. And this is the results that we looked, or these are the different centers. So that was Beaumont, Vincent's Hospital, and a lot of patients from Cork with Mike Henry down there, Professor Mike Henry. And it looked like really there's quite a lot of people with fibrosis. So nearly 62% of people with fibrosis in Ireland have this MUC5B gene. That's high. Usually it's about 40 or 50%. But a bit over half have one gene, and about nearly 8% have 2 genes. And it does make a difference. While this gene increases your cause, it increases your chances of getting fibrosis, it also somehow protects you when you get fibrosis from either your survival level. So if you have one gene, or if you have no gene, your survival level is around 3.5 years. If you have one gene, it's 4.5, and if you have 2 genes, it's longer. It's about 5.5 years. Now, this is all before really most of this data was taken before antifibrotic therapy, so survival times were less, I think, and I think we mentioned that earlier today. So this is really interesting work, and it hasn't been carried out in Ireland before, and ILFA is putting this together with the population data on to try and publish this work. But what about those rare genes that I spoke about? So let's look at those. The rare genes can be from really 2 different types, and they usually affect the lung exchanging cells right down in the air at the bottom of the lungs. So the rare lung gene can be either from the telomere, so that's something that's on your chromosome that protects you from, it gets shorter as you get older, and some of these patients actually have an advancing age of their lungs, we think about it. And that's about 20% of patients who have a family history can have one of these genes, and you can affect people less than 50. So it's really uncommon to see IPF in that population that are less than 50, but we do have patients that are less than 50. And then there's other genes that are related to surfactant, which is to do with how much surface tension is at the lung basis. This mostly affects children, but can affect adults. It's relatively uncommon. So just to describe a patient, so I think that gives us a bit more information. So this is David Crosby and his wife Kate. David had received a double lung transplant. He had fibrosis, and a lot of his family members were affected by this fibrosis. And they're obviously very concerned to find new treatments for fibrosis as well, because David was affected so young, and his siblings unfortunately died at a young age with fibrosis. There's no effective treatment. There's lots of different genes, and the rarity of these genes means it's difficult to work in the lab on this type of fibrosis. But we've now started a larger study to look at what the level of genes is across Ireland. So I'm going to describe that for you. So the first aim of that study is to find out how many patients with familial disease have a causative gene. And we've established a network across Ireland, with collaborators in most hospitals across Ireland. And our aim is to collect and interview and take genetic samples from 100 patients with familial disease and 100 patients with sporadic disease. And Eva Cahalan is helping with that. And we'll also look at different clinical signs from those patients. And what we want to do is find out, how does a single gene mutations affect disease behavior? So do people with that single gene, do they have a more severe disease, or do they progress or get worse in a quicker way? And we also want to understand, if we have some of those genes, does it matter if we have more than one gene, and does that add up to a bigger risk for fibrosis? And Jisha Jasmine in the labs are working on that. And finally, just to mention, we have some laboratory-based research, and that's largely headed by my postdoctoral fellow, Marie Ozaki, PhD student Anya Schweikart. And this is using those induced pluripotent stem cells. So those are adult stem cells that we can make from patients to make lung cells and test what's happening at the cellular level. And the hope there is to find out if there's a role for sex hormones. So is it worse in male or female? And Dr. Ozaki is looking at that. And also to find new therapies. So we've a big grant from European Research Council to find new therapies for fibrosis. So I'd just finally just say that it's really important that we have research networks across Europe and across the world to look at fibrosis, and we've established one and had a training school here in Dublin in RCSI to have people come and work with stem cells from patients. And just to summarize, so we're starting to understand the role of genetics in fibrosis, and we've just shown you some work on this risk gene called the MUC5B. We also are really interested in finding these rare mutations because they have really significant effects on the individual patients, and they may also help us to understand what's happening in fibrosis more generally. We're recruiting patients to several studies in Beaumont and RCSI, Royal College of Surgeons, and we've researched on new treatments, and that's happening in Ireland right now. So, of course, I'd like to thank my sponsors, charity partners. I have some contacts, but most importantly, if you would like to contact us about being involved in a research study, here's the steps you could do. Contact your GP or specialist for a referral to our clinic in Beaumont. You can email directly aoife at beaumont.ie, and I can circulate this email and this also this flyer later as well, and it'll be available from ILFA, or you can write directly to our clinic, and we'll reply to you and tell you how you can become join us in the research. So that's all I have today to talk about, and I'd be delighted to take any questions that you had. Thank you.
Wonderful. Thank you so much for that. And just a couple of things have come in on the chat. There was one question for the previous presenter talking about how they had received advice about being inactive as opposed to being active. We can't comment on individual cases, so that's one thing, but it would be good to maybe get a little clarification on that now that you've attended this webinar and heard this advice about the more active you are, the more that helps. just make sure that was the advice given. There's also specialist clinics across Ireland for pulmonary fibrosis, and if you haven't had a chance to be referred to those, that might be an opportunity for you as well. There was another question that came in, and I'm not sure, Professor Murphy, if you'd be able to answer this, but there's a question: is there a known link between COVID and pulmonary fibrosis?
Yeah, that's a great question. We know that because we've had CT scans of people who after COVID, and in certain age groups, around 7 or 8% of people do have some changes which might be consistent with early fibrosis after having severe COVID. So that's people who are admitted to hospital with severe COVID. But that link is not as solid as we would like it to be. So there's ongoing research to look at that. We definitely know that people who have pulmonary fibrosis, they're at big risk when they get COVID. So it's something to really avoid. So that's a thing that's really more established, and that outcomes from people who have fibrosis who get COVID are poor, and trying to avoid that. So making sure that you're up to date with your vaccines, and then maybe being more cautious, particularly with air travel, about wearing masks in crowded areas and avoiding people that are sick, I think is good advice.
Great. Thank you so much for that, Professor Killian, Hurley, Dr. Aoife, Cahalan. Really appreciate your time and that really interesting presentation.
You're very welcome.
So before we wrap up, we are going to have a patient story from Tom Murray. Tom, you've been very patient with us. And if you could please unmute yourself and tell us about your story.
Thank you, Maureen, and good afternoon, everybody. Tom Murray is my name, and I was diagnosed with pulmonary fibrosis in 2016. And I was told at the time that I would probably get 5 relatively trouble-free years, which I did. And in 2021, my condition worsened to such an extent that I was only able to walk very short distances, and I had to go on oxygen. And that was in early 2021. So on the advice of the respiratory nurse, I joined the ILFA Zoom classes, and they were a great help at the time, even though I struggled with them. But I think that they were a contributory factor to when I did get assessed for a transplant, that I was accepted onto the transplant list because I had done some work on my fitness. And luckily enough, I was only on the transplant list for a number of weeks, literally 3 or 4 weeks, when a potential match came up. And it actually was a match. And I got a single lung transplant. That was in the autumn of 2021. The same year, actually, that I was, condition went from 10 to 0. And after the transplant, then I was in the hospital for 10 weeks because I had issues I had heart problems. I had previously got 3 stents put in, and I suffered a number of infections. And just to bear in mind that this came through the period of COVID as well. So we were all in single rooms. It was a very isolating period in the Mater Hospital. But look, the expert, I suppose you could say that it was second to none, the transplant team's care and attention and professionalism, and you name it, they pulled out all the stops because the recovery was pretty hard. I was there for 10 weeks, and after that, I had to attend the clinic very regularly in the first few months, maybe twice a week, which meant traveling from the west of Ireland up to Dublin. And because of my immune condition, we weren't allowed to travel by public transport or go in anywhere to get a cup of tea even. So we literally brought everything with us in the car, food and everything. And the rehab went well, and the physios got me moving again. And when I was back doing, almost a year after the transplant, I had been doing really well, going out football matches and everything. And I went and had a heart attack at a football match, which was in a way a blessing in disguise. There was 3 nurses standing beside me, and they got me kick-started again, and got another stent put in subsequent to that. It was almost a year to the day of the transplant. So I found it difficult recovering from that, because I had sort of mentally prepared myself for the transplant, but this blindsided me. So it took a while to recover from that. But I got back walking, and I got back doing an exercise bike, and I resumed the ILFA classes, which are the reason that I'm so good now, in my opinion, because of I do them twice a week, and it's a compulsion now with me not to miss them. And look, I suppose I was lucky that a lung came up when it did, because as the consultant in the matter told me, my window of opportunity was diminishing all the time. So I've a lot to be thankful for in one way. I suppose you could say that I was unlucky to get pulmonary fibrosis, but I was lucky to get the transplant. And that's why everybody should be a donor. And look, the whole process was pretty, I had a very positive attitude towards it, and I think that everybody should. And it will get.
Tom, you've muted yourself.
Yeah.
You've muted yourself there, Tom.
Hopefully, yeah.
No, I was just going to say I'm back doing very well now, and walking 2 to 3 miles a day, and have an exercise bike. I have a very specific exercise regime, and that's basically my story so far, anyway. And I would like to thank all of the healthcare professionals that have looked after me, because it's been absolutely brilliant. And ILFA plays a key role in all the techniques that allow you to breathe freely without getting stressed. And that a lot of it is down to the technique, and that's what I put my recovery to. So thanks very much for allowing me to tell my story.
That is an incredibly powerful story, Tom. Thank you so much. Thank you so much for sharing that with us. And really, really brilliant to see. And I'll be looking forward to watching your next marathon.
I'm 68.
Yeah. Eddie, that was incredible, wasn't it?
So, thanks again, Maureen, for very, very professional performance, I have to say. Anyway, as we approach the end of today's event, I would like to thank you, Tom, and I wish you all the very best. You never know, we might get a marathon out of you yet. Give it time. But I would like to thank everybody for today. I would like to acknowledge the great series of talks, and extend a special thanks to Boehringer Ingelheim for supporting this wonderful event. Thanks a lot. It takes a lot of planning, preparation to deliver these events, and I am grateful to our wonderful speakers for their time, expertise, and dedication. Thank you again to Gemma and Anne for their work and dedication as well, and to Justin Dawson for his expertise in overseeing this online event. Thanks again, Justin, for everything. Warmest thanks to Maureen O'Donnell for managing our live event so expertly. And today's series of talks covered all of ILFA's key aims, namely education, research, advocacy, and support. Yeah, ILFA's work is made possible by the efforts of our amazing fundraisers and donors. ILFA does not receive any government funding. We rely on donations, and all support is gratefully received. To donate, please visit www.ilfa.ie. And if you would like to fundraise for ILFA, please get in touch. If you're a family member or a member of a club, society, or company, please consider ILFA as a potential charity partner. We would truly welcome such an opportunity. We hope you enjoyed this Patient Information Day. Thank you all for attending, and we hope you will join us for the next one in the not too distant future. Wishing you all a lovely weekend. Stay safe, stay well, agus slán.